Hello, my name is Julia Chernis. I'm a first-year fellow from the University of Colorado, and today I'd like to talk to you about a case of myocarditis in a Still's patient. We had a 41-year-old male with adult-onset Still's disease diagnosed 10 years back that was well-controlled on canakinumab, who presented to the University Hospital for 2 months of worsening myocarditis symptoms. Outside, he had a clean left heart cath, and there was no underlying diagnosis yet made. As the rheumatology team, we were consulted by cardiology to assist with the underlying etiology of his myocarditis, which they suspected may be due to his underlying Still's disease. Because of the fact that his Still's symptoms were pretty well controlled at the time of his presentation, we suspected an alternative diagnosis. When he initially came in, there was a suspicion for Graves' disease due to a depressed TSH and elevated T4, for which he was started on methimazole. And throughout his hospitalization, he had intractable arrhythmias and worsening EF on his repeat echocardiograms. One of the things that we ended up getting during his hospitalization was a PET and SPECT scan, both of which showed that he had decreased perfusion in both his right and left ventricle and corresponding inflammation in the areas of decreased perfusion. Afterwards, we ended up getting a myocardial biopsy that did show giant cells on the biopsy and cinched the diagnosis as giant cell myocarditis. Prior to presenting to us at the University Hospital, given the suspicion for myocarditis, he was started on high-dose steroids and was on high-dose steroids throughout his hospitalization. After the diagnosis of giant cell myocarditis, he was started on tacrolimus as well as mycophenolate and given IVIG. In terms of giant cell myocarditis as an entity, it is an incredibly rare form of myocarditis, and it typically affects men and women equally, and typically is found in young to middle-aged patients with a very low incidence. And the times that one should suspect giant cell myocarditis are if you have myocarditis with an acute and fulminant picture that progresses very rapidly, and in a patient that has severe electrical instability, as with our patient and his recurrent ventricular arrhythmias, and high-grade AV block, as well as if you are having a patient with biventricular involvement of their disease. And treatment is quite aggressive after you get a biopsy to prove the diagnosis, and it requires high-dose steroids as well as immunosuppressive therapy with a calcineurin inhibitor, in addition to mycophenolate or azathioprine, or a regimen of ATG or emmetuzumab. Both of these, in combination with goal-directed medical therapy, can take your prognosis from 3 months to 12 months from presentation to either death or transplant of the patient. And despite treatment, unfortunately, transplant is often necessary. As with our patient, we were able to get him a transplant. He did end up getting a transplant at this point 9 months after his diagnosis, and we were able to get him so as I mentioned, we were able to get him a transplant, and he is doing well. Mahalo, thank you.